Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight is the optometric role in the diagnosis and management of headaches. And with this presentation, we have a tremendous presenter, Dr. Patti Modica. She's a graduate of the Pennsylvania College of Optometry, where she's completed a residency in primary care, followed by a 2-year fellowship in neuroophthalmic disease. She is currently a clinical professor at the State University's New York College of Optometry, where she oversees care in the neuroophthalmic disease service and teaches didactic coursework in neuroophthalmic disease and neuroanatomy. She also participates in clinical research involving concussive disorders. She lectured nationally and internationally on topics related to her clinical emphasis in neuroophthalmic disorders, and has published Neuroophthalmic System Clinical Procedures by Butterworth Heinemann. She's an active fellow of the American Academy of Optometry and currently serves as the chair for the Special Interest Group Neuroophthalmic Disorders in Optometry. Patti and I go back a very long time. For virtually our entire career, we've known each other. She is a great friend, a great colleague, and a great educator, so I'm really looking forward to hearing this. So Patti, with that, please take it away.
Okay, thank you so much, Joe, for that very nice introduction. I was impressed anyway. But anyway, I'm really happy to be here with you guys tonight. And I just want to let you know that when it comes to dealing with headaches, our goal here is not to be headache experts, at least not people who have to diagnose and get the right diagnosis. We really just have to address and manage our patients that come in with headaches. We have to know what to do with them. So I hope that I can give you some important information that might help you to sift through the patient with headaches and maybe break it down to a more simple approach. So I have no financial disclosures. Let's just start with a little bit about headaches in the eye. So, when we get patients with a chief complaint of headaches, a lot of times it's their primary doctor that said, go see the eye doctors. And what they're really looking for from us is they just want us to patient has headaches, they want us to be able to say, they need glasses or they have eye strain, and if we don't find any of those things, then their expectation is, all right, now we have to manage the patient medically. But I think, and I hope that after we're finished tonight, you guys will see that there's a little bit more, well, not a little, a lot more that we can do. So our role is really looking at, does the patient have asthenopia or do they have some type of ocular or intracranial disease process? We really need to be doing that. Is the pain ocular or intracranial? There's shared innervation between the head structures and the eyes, so it's hard to tell sometimes where the pain is coming from. And then what's our role in management? I said patients often go to the optometrist first, and but from our end, a lot of the patients that we do see are being managed completely inadequately. And if we can recognize that, we can sometimes, or very often, at least in my service, I often get patients back on the right track when it comes to their pain management. Okay, so what are the pain sensitive structures in the head? Well, they include our muscles, any muscles in our scalp, our blood vessels, our venous sinuses, which are the channels that drain blood from the brain. So they're formed by veins themselves, but also splitting of dura that channels blood into the actual veins. We have meninges, the coverings of the brain. We have these structures within the scalp, and all of them share innervation. Their pain pathways are the same pain pathways that are coming from the eyes and the adnexal tissue of the eyes, and that's why it sometimes can be confusing. Patients with a problem with their eyes can have pain in their head, and likewise, patients with a problem in their head can have pain manifested through the eyes. So that's another reason why they may come. So I like to break headaches down to 3 types. Okay, we have asthenopic headaches. That's the refractive errors. Patients are straining through bad refractive errors, or they have binocular or accommodative disorders. And these are patients who say their headaches are exacerbated by near work. And a little caveat, with smartphones, I got one in my hand right now. Sometimes patients are sitting like this over their phone. They're getting headaches not because they have an asthenopic problem, but because they're straining the heck out of their cervical muscles. So always ask about their posture or observe their posture, and that can sometimes give you some good information. Primary headaches are headaches that really have benign etiology. There's no tissue lesion that's identified. Somehow they just have activation of their pain networks, their trigeminovascular nerve endings. And that we'll get to why that happens, but there's really no tissue lesion. They don't have a tumor. They don't have anything horrible going on. They just feel like garbage. And then finally, we have secondary headaches. And secondary headaches, these patients have an identifiable tissue lesion. That might be a tumor, compression, a compressive or structural lesion. It might be traction from raised intracranial pressure or neck traction from an injury, inflammation of either the coverings of the brain, the dura, the nerves, the blood vessels. And when we do have these secondary types of headaches, they're very, very often associated with red flags. So we'll spend some time talking about some red flags that you should be on the lookout for. Now, by far the most common headache disorder that you're going to see clinically is migraine. Migraine is these are patients who have episodic headaches, and these headaches have typical features, the most important of which are photophobia and sensitivity to sounds, but they're broken down into two main types. They either get an aura with their migraine or they have no aura with their migraine. And then there's a couple of distinct migraine types. We have retinal migraine, and that's of significance because of our specialty. Not that common, but we do have to mention it. And then ophthalmoplegic migraine, even more rare than a retinal migraine, and probably isn't even a migraine. We now know it to be something else. That's what the little stars there are for. But I'll just quickly tell you a little bit about those. So who gets migraine? Well, as many as 18% of women and 6% of men get migraine headaches. So those are pretty high numbers. This is a very, very common disorder. As many as 23 million Americans have migraines. So the challenge with migraines is not only that it's common, but that most migraine patients have not been formally diagnosed by a physician. They just get headaches that are frequent, and they just name them migraines on their own, or maybe they know from family members who get migraines. They're called migraines, and that's how they get diagnosed. Most of the patients with migraines are using only over-the-counter meds, and many are treated ineffectively. So this is where we can step in oftentimes and help. So what do we now know about migraine? We were always taught way back in the day, if you remember, Joe, migraine was a vascular disorder caused by vasodilation, but that's really not the case. What we know now is that migraine is really a neurovascular disorder. There's a neurological event that does cause a vascular response that then leads to the headache. Also, the migraine aura was thought to be caused by ischemia. So we got ischemia that was followed by vasodilation, and the vasodilation caused the headaches. And that's not true either. And I'll get to that in a little bit. And then finally, the predisposition for migraine is actually inherited. So you either have migraine genes or you don't. And if you do have migraine genes, then there are going to be certain triggers that will expose that gene or make that gene manifest itself. So quickly, genetics, I don't want to get too crazy with this slide. Just understand, there is a genetic tendency that results in a very heightened sensitivity to certain triggers or certain stimuli. And they've actually identified mutations on chromosomes 19 and 23. There's also some variation that's been identified within dopamine receptor genes, dopamine specifically D2 receptors in patients with certain familial migraine disorders. And then there's a whole bunch of other ones that have been, that are felt to be related to migraines, which, we don't have to get that crazy with it, but this is a nice citation if you're interested. And Joe, I know you asked me for the PDFs, and I will share that PDF with you. I meant to do that sooner, but I will. I might need a reminder. Okay, what's this neurovascular mechanism of migraine? Well, there is a defect in ion channels within the nervous system, and that defect leads to hyperexcitability of neurons, and that leads to activation of this trigeminal vascular system, which is the pain system that is associated with migraine headaches. So we have these little sensory neurons. They originate in our trigeminal ganglion. What's the trigeminal ganglion? That's the ganglion, associated with the trigeminal nerve, and it's sitting in the pontine level of the brainstem. So neurons, once this system is activated, neurons that innervate cerebral blood vessels and meninges and veins, they become activated. And we actually can see a dysfunction of brainstem ion channels that impairs serotonin release. Remember that word, serotonin, that's a neurotransmitter. And that predisposes patients to the migraine, or it impairs a self-aborting mechanism. So that mechanism would be responsible for, kind of fixing this short circuit in the pathway and stopping the pain. And this just doesn't work. So activation of this trigeminal ganglia, the trigeminal ganglion, causes a release of neuropeptides. Those are associated with neurogenic inflammation, and that leads to vasodilation. And then guess what? Vasodilation will then lead to release of more neuropeptides, and the cycle is perpetuated. So pain signals are reaching the thalamus via the trigeminal ganglion, and then the thalamus is projecting those pain signals to the cortical structures in the brain, and that's how we perceive the pain. Now, migraine medications, and the reason I'm sharing all of this with you is because it's important for you to understand it, because migraine medications, they block migraine-specific medications anyway, block release of neuropeptides. That leads to constriction of these dilated blood vessels, and that can block the release of the neuropeptides and end that cycle. In addition, there's other medications that are not necessarily migraine-specific, they're just pain medications. They can also be used because they block trigeminal nerve pathways, and they modulate the neurogenic inflammation that can result from activation of this whole system. So that's, migraine in a nutshell. Now, I mentioned neuropeptides, and probably the most important neuropeptide that's released in migraine sufferers is a peptide called calcitonin gene-related peptide, or CGRP. So this neuropeptide is it sensitizes peripheral nerve, and those sensitized nerves now send signals back to the nervous system, and that triggers pain. And it happens because it binds to a receptor, and then it sensitizes the nerves by increasing their rate of firing. And it's also felt that CGRP activates pain receptors by directly dilating blood vessels, and that causes irritation of adjacent pain receptors. So it's a kind of a new thing, and a lot of the migraine therapy is targeted at this particular neuropeptide. Okay, let's talk about migraine, and to start, we'll talk about migraine that has no aura. So these are patients.
Patti, can I just launch the this poll here that I think would be important, if you don't mind? This is one is how comfortable are you with addressing the chief complaint of headache? I think this is kind of cool because I think we have this in here twice. So I'd like to kind of get it done before, and then we'll see what happens after. If you don't, thank you for letting me do that.
You bet. Yeah, just let me know whenever we want to put one up there.
When you need an inhale and an exhale, I know we don't have them kind of scattered throughout your slide deck, so we'll just kind of every couple minutes.
Yeah, whenever you do it is fine.
Okay.
Fine.
All right. So here you go. I think this is timely and why we have a good audience tonight. So.
Okay. All right. So we're kind of, the majority of us are somewhat comfortable. So we're aiming for very comfortable. Let's see what happens. Okay. So migraine, moderate to severe headaches lasting hours, sometimes even days. Patients very often have nausea, sometimes vomiting, but two big ones, photophobia, sonophobia, very, very common with migraine sufferers. Triggers, they can occur. And remember, we said there's a genetic tendency, and with that genetic tendency makes us sensitive to certain triggers. So the triggers can include stress, estrogen deprivation, foods, weather changes, sleep deprivation, and I'll get a little more into those in a little bit. But migraines are typically relieved by sleep. Patients say, look, I sleep it off, I wake up and I'm fine, but ideally, they'd rather have something other than a nap to get rid of their headaches. In the overwhelming majority of patients, there is a positive family history that speaks to the genetic component that I mentioned earlier. And then finally, the peak onset is in the second and third decade. But then there's a second peak that is around menopause in women. So keep that in mind. Migraine with aura, this is just the same as regular migraines. The only thing different here is that there's a transient neurologic deficit that precedes the headache. Okay, so that deficit most commonly is a scintillating scotoma. We're familiar with this, the fortification scotoma, but it doesn't have to be that. It can also, some migraine patients say, I get numbness or tingling before my headaches. Others have in more rare instances, aphasia or hemiparesis. So these are, there's a familial headache type, specific gene causing a hemiplegic migraine, a very strong family tendency there. Aura can occur without the headache, and when that's the case, we refer to it as an acephalgic migraine. Not quite as common, but it happens. Aura is typically consistent, meaning if their aura is a scintillating scotoma, then that's their aura. It may switch hemifields. Sometimes they may see it to the right, sometimes they may see it to the left, but that's the aura that they get. They don't get scintillating scotomas one time, then paresthesias another time, and aphasias another time. Their aura is unique to them. And then finally, differential diagnosis. When patients give these types of complaints about auras, we have to make sure, are they having a seizure or are they having a TIA? And certainly worry about TIA if it's an older person complaining about things like this. Seizure is if there really isn't a migraine history and you feel like you need to take a deeper dive into the cause. Visual aura, we know this one. This is the scintillating or fortification scotoma. It starts out small, gets gradually larger. I've had patients tell me different things about their scotomas. Sometimes they say there's colors, multiple colors. Sometimes they're one color. One patient said it reminded her of the Statue of Liberty, which kind of is true. Another person said it reminded her of Lisa Simpson's hair. So these are the ways in which your visual aura can present. Now, the aura was always thought, we were always taught that it was ischemic in nature, but it's not. It's actually due to a depolarization of neurons, and it just kind of spreads across the cerebral cortex. So one neuron triggers it in its neighboring neuron, and so on and so on. And then, and this is what ultimately activates trigeminal afferents, which then get the pain cycle started. Okay, so that's what's really happening when we have a migraine aura. And we refer to this as a cortical spreading depression.
Hey,
Retinal
Patti,
migraine.
does depolarization mean that it's firing? Help me out with that?
Yeah,
That's a true question that I have.
Good question. Depolarization means the neuron is firing. When it hyperpolarizes, it stops firing. Okay, so now retinal migraine. You're going to hear, you have some patients who complain of transient vision loss. And when it's a young patient that isn't prone to getting ischemic events, sometimes their transient vision loss is due to retinal migraine. The only way to diagnose this is to actually see them when it's happening, in which case you can see some narrowing of the arteries and even the veins in the arteries. Sometimes you can see some segmented blood flow. Sometimes you can see frank gaps in flow, and then later on we get resumption of flow. You're only going to see this if the patient arrives at your office symptomatic. The reason we label these types of events as migraine is because they are so much more common in patients who have a family history of migraines or a clear history of migraines. So we know they're related to migraines. So keep that in mind. You might see patients like this and always ask about family history. It represents vasospasm, and it's typically reversible. Now, ophthalmic migraine, I have to mention it just because even though it's rare, it's something that we see. We're optometrists. So we actually aren't even classifying this as migraine anymore because it's now been demonstrated that this is actually a neuralgia. So these are patients who get a severe hemicranial headache, and it's accompanied by a third or a sixth nerve palsy on the side of the headache. And that palsy outlasts the headache. So the headache goes away, the palsy persists, and eventually recovers. Very, very rare. First attack occurs in childhood. And the problem with this is when you get a sixth or third nerve palsy with severe pain, especially if it's a third nerve palsy, we worry about things like aneurysms. We worry about some other type of inflammatory disease, even a compressive problem, because this happens in kids, and kids don't usually have vascular etiologies to the problems. They tend to have more tumors and inflammatory diseases, and that's why it scares us. Okay, what are the triggers? What precipitates migraines? I think we're all familiar with these, but we have stress. We have in women, menstrual cycle, lack of sleep, really, really big one now. Nobody sleeps anymore. And then we have excess sleep that can lead to low blood sugar, and that can trigger a migraine. Hunger, again, low blood sugar related. Certain foods, especially cured meats with their nitrates or chocolates, wines, unfortunately, especially red, my favorite. They can trigger migraines in susceptible people. Some patients have exercise as their trigger, and others have bright sunlight as their trigger. Some have odors as their trigger. Those are a little more unusual. And then there are patients who say, I swear I'm getting a migraine. I know we're getting bad weather, and barometric pressure is triggering their migraine. So these are all things that patients have reported. And I find it really, really useful if you want to try and help a patient identify their trigger. Using smartphone apps is really, really useful. So the eye headache app is the one I often advise patients to go to, but believe me, there's a number of them out there. They're free, and they can actually record their headache, record how much sleep they got, what they ate, when they last ate. So, and it helps them to identify what their triggers are. So this can be a really useful tool. Tension headache is also a primary type of headache, meaning, yeah, there's no tissue lesion. These are patients who have mild to moderate episodic head pain. They'll describe it as tightness or a vice on their head. That's not my Barbie. I found it on the internet. But anyway, they don't have photophobia or sonophobia. And that's what makes these different from migraines, although more and more we're beginning to think tension headache may simply be a variation of migraine. At any rate, the mechanism is unknown. It's thought that the tightness in cervical muscles is somehow activating that trigeminothalamic pain pathway. These are very common. They don't usually stop people dead in their tracks from doing things the way migraines do, but they can have an impact on their quality of life. Cluster headache is also a migraine variant that is very unusual. It's not very common, but patients with cluster headache will report attacks of severe unilateral periocular pain lasting up to 3 hours. And the reason this is such an important one to us, even though it's not that common, is at the time of their attack, they report conjunctival injection. Their eyes are red, or on one side, their eye is red. They're tearing. They have nasal congestion on that side and a runny nose on that side. And they may even have a Horner syndrome along with that. And I just had one of these patients last week, had been to a number of different doctors, and no one really had an idea of what was going on with her. And I made the diagnosis based on history. I didn't see her when I had her acute attack. I got her to a pain management person who'd be more comfortable dealing with that one. Okay, what about secondary headaches? These are the ones that are not migraines. They're due to some structure, some problem that we can identify or define. That might be a structural lesion, like a tumor. It might be toxicity to something. Could be just toxicity to a drug. Could be a metabolic abnormality, like we see, say, with altitude sickness or alcohol consumption, or even a medication. It can mimic any of the primary headache disorders, especially if we're unable to identify what that definable cause is. Sometimes it can be tricky to uncover what's going on. The pain may be from the eye or any of the pain-sensitive structures in the head. So, we're thinking secondary headaches when the patient says, I got hit in the head, and now I have a headache ever since. That's a secondary headache. It's secondary to their trauma. A patient who has papilledema associated with their chief complaint of headache probably is dealing with some sort of secondary headache disorder. And there are a number of other causes of secondary headaches. If we start with just the ocular causes of secondary headaches, I think we're all familiar, but any corneal disease or corneal drying problems, we know that cornea is highly innervated by the trigeminal nerve. And so corneal problems can lead to pain that can work its way back through the whole side of the head. Inflammatory disorders involving the eye, elevated intraocular pressure, chronic ischemia to the ocular structures, accommodative spasm even. All of those are ocular causes of pain, and the patients may report eye pain, they may report head pain in these instances. So basically, the optometric evaluation of any of our headache patients is going to require ruling out of all of the above. So I want to share a case along these lines. This is a 70-year-old male who reports pain in his right eye that radiates to the back of his head. He feels that his vision is distorted. He also, and that's just been like that for a little while. The pain, he describes it as a pressure sensation and radiates backwards. He's 70, so we're concerned about giant cell arteritis. He denies any scalp tenderness or jaw claudication. His problem is intermittent. There's no provoking features that he can identify. There's no history of migraine or anything like that. He has no significant medical problems. He does have some pretty severe meibomian gland dysfunction, and to the point where he's got scarring with a right lower lid ectropion. And I didn't have the opportunity to see him when he first presented. I was called from the primary care service by phone to say, hey, we've got this and we want to share with you the results of his examination. So his examination, he's 20/40 in his right eye, 20/20 in his left eye. He's got a 2+ right afferent pupillary defect. He has SPK bilaterally, worse in his right eye with a lower lid ectropion. And he's got an intraocular pressure of 23 in the right, 18 in the left. And here are his visual fields. So along with that right afferent pupillary defect, he's got this visual field defect, kind of not necessarily indicative of any particular process, but it speaks to the fact that he's got some sort of optic neuropathy. So with that information, I said, well, and they also shared with me his OCT findings, a little, problematic on the image here. So he does have some RNFL thinning. He has some thinning of his ganglion cell layer. So this was concerning. He does have, a pretty fair amount of cupping in both eyes. And let's take a look. So I said, look, let's get him booked in my service, and I'll let's get an MRI to start with, and then we'll see him next week with the results of the MRI, and then we'll get to the bottom of his optic neuropathy. So we send him off for the MRI. He has an enhancing lesion of his right optic nerve. So again, this is somebody that now has an enhancing lesion of the optic nerve. I'm concerned about something inflammatory. I'm concerned about the amount of vision loss that he has and the fact that he could have some permanent damage. So I said, all right, without even seeing him, let's ship him off to someone who can put a name on this. I wasn't going to be in the office for a little while, so they got him referred off to another neuro-ophthalmologist because I was concerned that he might need a lumbar puncture, and I knew I wasn't going to be able to do that, get that done quickly. So he goes to see the neuro-ophthalmologist who measures his IOP and finds that his pressure is 50 in his right eye and 40 in his left eye. So he's had intermittent angle closure. Question is, did he have it at the time of his presentation? Was that his second or third year student who measured it and got 23 and 18? I don't really know, but he had chronic angle closure. Why it's really important to do a good eye exam, good slit lamp exam, and make sure that we at least identify occludable angles, even if they aren't associated with elevated intraocular pressure. So what are some of the other non-ocular causes of pain now beyond the ocular ones I mentioned? Well, we have dental pain. Dental pain, I always ask, does it get worse when you chew? And I got burned on a patient who I ordered an imaging study for. It was normal, and she came back, and I said, I think we need to get you to see a pain management specialist. And she threw out, oh, by the way, could this be caused by a problem with my tooth? And I said, yeah, why? And she said, well, because my dentist told me I needed a root canal. And I said, all right, well, you probably should have just done your root canal before we did your MRI. And actually the root canal fixed her pain. So she was actually having a dental origin of pain that she was feeling in her eye and head. Here's another case report. This is a 38-year-old female who's referred for evaluation of headaches. She reports the onset was several months earlier. The pain is unprovoked. It's nearly constant, and it's worse when she bends over. saw her primary doctor, who prescribed Flonase, thinking it was a sinus problem, but she discontinued it 2 days later because she said, my goodness, it gave me such a bloody nasal discharge. I'm not taking it. There's no family history of a headache disorder. She's otherwise healthy and takes no other medications, but she is moderately obese and had some suspicious optic nerves. And I'll share with you, she just had some optic nerves with kind of small cups and indistinct margins. So what's the significance of the worsening of the headache when she bends over? When I hear that, what I think of is either sinus problems, or I think of intracranial pressure as a cause, as a possible rule out that we need to do, because those two things have been associated with worsening pain when a patient bends over. So, additional history. So she did not get photophobia, did not get sonophobia, had no associated nausea or vomiting. Pain was worse when she gets up in the morning. She feels a strong pressure sensation, and she also gets a pulsatile tinnitus, mostly in the evenings, but no double vision, no transient visual obscurations. Her best corrected acuity is 20/20 in the right and left eyes. She has normal pupils, isochoric, no afferent pupillary defect, and her slit lamp exam is fine. Her motilities are good. She has no nystagmus, no EOM deficits. Fundus, clear media, pink, healthy optic nerves. There's small, minimal cupping, but distinct margins, healthy blood vessels, and she does have a spontaneous venous pulsation. That tells us her intracranial pressure can't possibly be high, so we can probably rule that out as the reason for her headaches, and her neurologic exam was good. Here's her OCTs, they look good. She does have a little bit of elevation here, but minimal cupping, spontaneous venous pulsation. We attribute it to just her normal just her hereditary disconfiguration. And we refer to this as pseudo-papilledema, and her ganglion cell IPL layer looks good. And here's her visual fields. They look pretty good as well. There's no evidence of any focal deficit that would signify an intracranial process. So what kind of headache do we have here? Do we have asthenopia? Do we have a primary headache disorder? Do we have a secondary headache disorder? So let's take a look. There's no exacerbation with ear work. She wakes up with them, so it's probably not asthenopia. Is it a primary headache disorder? Well, she doesn't really have typical migraine characteristics, most notably no photophobia and sonophobia, and she can't sleep it off. She wakes up with the headaches. That's the opposite of what we expect with the migraine. There's no family history. So all of these kind of go against a primary headache disorder. And then now we have secondary disorder, headache disorder. Can we identify any red flags here? I felt the red flag was that she had them when she woke up in the morning, and they were worse when she bent over. So that red flag is kind of a mild red flag. She doesn't have papilledema, so we're not worried about an intracranial process. I was most concerned that this woman had some chronic sinusitis. Okay, so here's what we told her. We told her, we agreed with her doctor that this really was most compatible with chronic sinusitis. The other thing is, she said she got a bloody discharge after Flonase for 2 days. Flonase isn't going to do that. Flonase can cause nasal ulcers, and that can lead to a little bit of very, very mild bleeding, but it takes usually like a months of use for that to happen. And it doesn't cause a bloody discharge. Sinusitis, though, can cause a bloody nasal discharge. And I said the Flonase was probably helping your sinuses drain, and that's probably why you were noticing that discharge. So I recommended that she just go back on the Flonase and come back and see us 3 weeks later. And in fact, she didn't come back in 3 weeks. She called me instead to tell me that the headaches were better and the regular use of Flonase helped. So she had a secondary headache disorder due to a mild, a chronic sinusitis. So little questions like this are important to ask when the headaches don't follow that primary headache type of pattern. Okay, paranasal sinus disease, typically causes headaches that are worse in the morning and worse than when bending over. So that was our clue. Any of the paranasal sinuses can lead to periocular pain because they surround the eyes. Take a look at their proximity to the orbits. And infections are most common. Whether they're low grade or acute, they can all cause pain. Okay, what about neuropathic pain? I think we're all familiar with post-herpetic neuralgia or any kind of trigeminal neuralgia, but we're certainly familiar with post-herpetic neuralgia because we often treat it. Then we also treat the primary herpetic infection. So these follow a herpes zoster dermatitis. Patients get a very burning pain, and they might also get some short stabbing pains that are triggered by light touch. Trigeminal neuralgia causes a similar feeling of pain, only it doesn't occur after a herpetic event. It just occurs because something is irritating the trigeminal nerve. Sometimes that can be an inflammatory disorder. Sometimes it can be a structural disorder, and sometimes it occurs by itself. But patients get unilateral jolts of very severe, almost electric shock-like pain. And it's triggered by eating, by talking, by light touch, even breezes on the face, or even brushing their teeth. Sometimes the pain will precede a vesicular eruption. I've had patients that come to me. I'll see that they have pain and say, well, it sounds neuropathic, but I don't see anything, any vessels or anything on your eyes. It might be triggered by something else. And then a few days later, they have their vesicular eruption, and that's how we make their diagnosis. Intracranial pressure is interesting. We know that patients with elevated intracranial pressure can have distension of their veins, and the veins are pain sensitive. So they can have distension of their intracranial veins, and that can lead to some headache. But also decreased intracranial pressure. When would you see decreased intracranial pressure? Well, if you have a patient with papilledema that you send off to a neurologist for a spinal tap and a workup, after that spinal tap, there can be persistent leakage of cerebrospinal fluid. And that leakage can cause intracranial pressure to drop. And when that happens, patients have a pretty severe headache. That's worse when they stand up and better when they lie down. So I always ask, and if it is your patient that was referred off to someone and they say, ever since that spinal tap, I've got a headache, or I woke up with it, they need to go home after a spinal tap and lie down so that their needle puncture will close up better. And if they decide, I feel fine, I'm going to go back to work, or I'm going to go jogging or hiking or whatever, they may wind up with a persistent CSF leak. The other times we see decreased intracranial pressure is after any type of epidural injection for anesthesia, whether it's surgical or whether it's to address back pain. So always inquire and put 2 and 2 together when you've had a patient who's had any type of spinal injection of any sort. Here's another case. This is a 48-year-old obese female with a history of pseudotumor cerebri syndrome, and she has a new onset of headache. So she was doing well, and suddenly her headache just came back. The headache is constant. It involves the base of her head, and she just feels out of it in addition to having the headache. So she feels like it's different from the headache that she experienced when she did have elevated intracranial pressure before we treated her with her carbonic anhydrase inhibitor. She does have what we call atrophic papilledema. So she had the papilledema for many years, and it caused some damage to her optic nerves in both eyes. So now she has optic atrophy. So we refer to that as atrophic papilledema. She takes a gram of Diamox, and she has done so since her PTC diagnosis was made by us, and fortunately her optic atrophy has remained stable. But I do worry about her because she does have a fair amount of compromise to her optic nerves. She's got some structural damage because she's got a lot of damage because she walked around with papilledema untreated for a long period of time. So this is what she looks like. It's really hard to tell if a patient with atrophic papilledema has an exacerbation in their pseudotumor cerebri because their nerves don't swell very easily. Why don't they swell? Because they're dead. There's a lot of dead axons in here, and dead axons can't swell up. Okay, swelling occurs when there's stasis of axoplasmic flow, and there's not a whole lot of axoplasmic flow happening when there's a lot of dead axons, and that's why you can see here that she really doesn't have swollen optic nerves. So I was worried because in this situation, I don't know if her intracranial pressure situation is back, but more importantly, she said it was different from what she had before. So she's got a change in her headache pattern, and that always warrants additional testing. That's a red flag. So I did image her. Her imaging study was normal. So I asked her to follow up with her primary. So her primary said, you know what, you're on carbonic anhydrase inhibitors. Maybe you're dehydrated. Let's increase your salt intake and your fluids and see what happens to your headaches. And her headaches got better. So this is probably a diagnosis that I should have made. I should have recognized, hey, she's been on this for years. And I guess I thought, well, why is she suddenly having a problem now? But I'll keep that in mind the next time one of my chronic pseudotumor cerebri patients comes in and complains of an increase in their headaches. Okay, so she basically had a metabolic type of headache, or maybe, I don't know that we could call it toxic. I'd probably call it metabolic because it was due to dehydration. But some of the toxic or metabolic offenders include alcohol, caffeine, nitroglycerin, nitrates that we see in cured meats. Niacin has been associated with headaches. Monosodium glutamate, real big toxic headache offender. Certain pain medications can actually cause headaches, as well as ergotamine. This can happen when there's either excessive consumption of the medications, or in the case of analgesics, it can happen when we withdraw them and they get a rebound in their pain. So we have to consider these. The metabolic causes include hypoxia, like we see in altitude sickness. I remember when the Academy meeting was out in Denver, I had horrible headaches the whole time because the altitude bothered me. And I have the headache gene, apparently. Air pressure issues, decompressive. Sometimes people notice them when they fly. Electrolyte disturbances. That was probably what was going on in our patient that I just presented. So knowing now we've got our primary headache disorders, our secondary headache disorders, we know about asthenopia as well. What then should be the approach that we should take with our headache patients? So
I'm going to launch another poll question here, Patty, just to kind of keep this synchronous and
good. I'm going to
refill
my water.
Perfect. All right. So what is the polling question here? How do you perceive your role in the management of patients with a chief complaint of headaches? Limited to ruling out asthenopia or refractive error, rule out asthenopia, refractive error, and perform a thorough ocular health assessment. A, B, an attempt to diagnose headache type, and render advice treatment strategies. So thanks for helping us stay compliant here, keeping this live and synchronous, Patty. I appreciate sending the questions, and also gives you a little break, and so you don't get a headache there and get dehydrated.
Yeah, the dehydration, big deal here.
You know, Patty,
very dry in Jersey.
Yeah, and when you mentioned Denver, it wasn't so much the altitude as I remember the cold. That was pretty brutal. But somebody asked earlier when you were talking about some of the triggers, they asked why was exercise a trigger for a migraine?
Okay, so exercise is probably a trigger for, it could be a number of reasons. It could be the elevation in body temperature. It could be just the metabolic changes that occur when we exercise that are doing it. We can release histamine sometimes when we exercise. So lots of physiologic changes in the body occur with exercise, and some people are just triggered by that.
Excellent.
Okay, so nice. A lot of people feel that their role is pretty advanced and they should not only try and diagnose, not only do the eye exam, a thorough eye exam, but also should try to put a name on the type of headache and give them some good advice on treatment. And that's good because that's exactly what we should be doing. Okay, so now let's talk about that approach. Okay, so what should the approach be? So the first thing, we do a good case history. It's got to be thorough and detailed. The only way you're going to differentiate the different types of headache disorders is if you really spend some time talking to your patients. It can include making sure you go through every medication, and not just medications, but any supplements that they might be on, and what are their social habits, what are their lifestyle habits. Okay, all of those can factor in to their headache complaint. The examination should involve checking all symptoms. I gave you a couple of cases where it was really important, like just the slit lamp exam is important to make sure you're not overlooking some ocular cause of their headaches. So very, very important. You know, I always tell students, just because you come down to the neuro-ophthalmic disease service doesn't mean you stop, doesn't mean you blow off the slit lamp exam, because there's a lot of clues to be had on even the anterior segment ocular health. The posterior segment is a little more of a no-brainer. The anterior segment is often just as important. Additional testing that based on what you find in your exam. If you find certain things and feel you have to now take a deeper dive, then by all means do it. I always like to include visual fields on my patients with headaches, because I want to make sure that's the best way for me to fully assess their visual pathway. I'm looking for bitemporal hemianopsias, or homonymous hemianopsias, anything that speaks to a problem in the visual pathway, and really even just deficits that could signal optic nerve disease that might be related to their headache complaint. And then finally, often, since we're not going to actually manage those headaches with medications, we're not the prescribing doctors here, we oftentimes do make referrals for the patients, and you have to consider who are we going to make that referral to. Okay, is it the primary physician? Is it a pain management specialist? Sometimes they don't need either. Sometimes they need to go to a surgeon to take out their pituitary adenoma. So we have to put it all in the context of the examination. So case history, we need to know the frequency, the severity, the associated findings, any potential triggers. And sometimes we don't know those triggers unless the patient starts taking a deeper dive with one of those headache apps that helps them log in all of their headaches and follow their patterns. Personal habits. I always ask, how much sleep do you get? Because I feel like more and more the lifestyles of patients right now are crazy. They don't get enough sleep. They don't get enough exercise. People just don't take care of themselves. They don't just take a breather and smell the flowers or anything. They stress out. So that's important. What's their medical history? Are there any clues there? And always the family history. Is there a headache situation running in the family? Always look at the pattern. Is it consistent with asthenopia or any of the primary headache syndromes? And finally, are there any red flags? And red flags, they're going to suggest a secondary headache disorder. So what are the red flags? If a patient's complaining of headaches, but they also say their headaches just started suddenly, their headache is severe, or maybe even uses, in the words of Larry Gray, the worst headache of my life. Okay, that's a red flag. The red flag for that one is, did they have bleeding? Did they have a subarachnoid bleed in their brain? Now, honestly, if a patient does have a subarachnoid bleed, that headache is going to quickly be followed by loss of consciousness or vomiting and all kinds of, maybe even a seizure. So they're probably not coming to their optometrist, but just keep in mind, if a patient does complain about that level of pain, they really need to probably be treated in the emergency room. Do they have a new headache pattern? There are patients who've had headaches, been headachy all their lives. But if they say, my headaches are different now, you've got to presume there's something else going on. Maybe there isn't, but you have to presume there is, and that means that always is reason for us to do an imaging study, an MRI, to make sure that nothing new is going on in your brains. If the headache is always on the same side, that's a red flag for structural disease. Migraine patients will favor one side. They'll say most of the time it's on the right, but sometimes I get it on the left. I'm always really happy when I hear that. But if they say, no, it's always this side, then that's a red flag, and I want to rule out a structural lesion. Have they ingested anything? Are they taking new medications, new supplements? That's, fortunately, we can oftentimes tell them to stop that medication, and it'll get rid of the headache, but it certainly is a red flag for a secondary headache. Are there associated neurological symptoms? They have a fever with their headache, a stiff neck. Do they have projectile vomiting and nausea? That's worse. That's not typical of headaches when it's like that. And so those are things to think about. Do they have an intracranial infection? And those are things that might be accompany an intracranial infection. And then finally, any high risk patient. What is a high risk patient? Someone who has a history of cancer, or who is pregnant, or in their immediate postpartum state, or anybody who's had recent surgery of any sort, or if they're immunocompromised. And the big concern here is infection. Okay, in the case of cancer, it's metastasis. In the case of pregnancy or postpartum state, it's raised intracranial pressure. So those are things we have to consider. If they're a high-risk patient, I often like to pursue their headaches, not with me, but with their treating physician. Okay, those are ones that, if somebody refers a patient to you and says they just had they had surgery and they have headaches now, I'm like, I don't want to see it. They got to go back to their surgeon. They got to bring that to their surgeons.
Patty, there's a quick question that came in into the chat. Waking up in the middle of the night with a severe headache, is that a red flag?
Yes, headaches that wake you up are red flag headaches. Now, the good news is sometimes headaches that wake you up during the night are actually a migraine variant. They can be cluster headaches. Okay. So that's good. The other things I ask patients when they say headaches wake them up in the middle of the night, I ask them what kind of pillow they're sleeping on. Sometimes patients just get cervical neck pain from a bad pillow that's causing a lot of tension on their neck. And so I ask them what they're sleeping on. And sometimes simply changing their pillow fixes their headache problem. And then other headaches that wake you up in the middle of the night are sinus headaches. But if you can't really identify any of those, then you do want to pursue things with an imaging study. But the good news is I find a lot of them tend to be benign anyway, even though they're red flags.
Patty, another question is, do you treat retinal migraine as a diagnosis of exclusion? At what point should we be comfortable diagnosing something like this when the differentials can be ominous? That's one of our chat questions.
Okay, and that's an excellent question, and they have to be treated as a diagnosis of exclusion. So, and here's the thing, you got a young patient who's getting with retinal migraines, so that they're presenting basically with transient monocular vision loss. Okay, and young people, even though they don't get carotid occlusive disease, they can have heart issues. They can have structural problems or rhythmic disorders of their heart that have nothing to do with ischemia, but that can throw emboli and cause transient monocular vision loss. So at the very least, they need a heart workup. So I will involve the primary care provider. I will say, there's a strong family history of migraine. This can be retinal migraine, but since retinal migraine is rare, it's a diagnosis of exclusion, and we probably should rule out a cardiac source of their transient vision loss.
Excellent.
Okay, so great question.
Another question that came to me directly. Somebody says they have many patients with neuropathic conditions like fibromyalgia who tend to frequently complain of stabbing eye pain when everything is unremarkable. Any tips here, aside from follow-up care with PCP management, pain management, with pregabalin or Lyrica?
Okay, so stabbing eye pains are actually, the first thing I ask, a patient with fibromyalgia, the first thing I ask them, first of all, headaches are a big deal in fibromyalgia patients. They have their little hot spots, their tender spots and everything, but they also do get pain. So a couple things, I can take a really deep dive to this question, or I can, but I'll try to just answer it quickly. The sudden stabbing pain could be what we refer to as or term ice pick pain. And these are little pain paroxysms that are very, very common in patients who have migraine headaches or any primary headache type pain disorder. So the good news is these patients, oftentimes all you need to do is reassure them that these are common. They're seen in patients with chronic headaches, and fibromyalgia patients have chronic headaches. The other thing is fibromyalgia patients, You know, we call it an idiopathic condition, but that's probably just because we just don't know what the actual cause is. Fibromyalgia patients, they probably have some sort of rheumatologic disease, and rheumatologic disease is associated with headaches in many instances. And so any chronic headache patient is going to get these stabbing pains, and it's related to their disease. And so I usually reassure patients if it's really frequent, they may benefit from indomethacin. That's the one NSAID that's been shown to really be effective at minimizing the frequency and severity of these little paroxysmal stabbing pains. So it's something that you can convey to their treating physician.
And I think
Okay,
the
so hope that
last of the
helps.
current, oh yeah, well, next to last of the current questions, do you recommend any supplements for migraine, such as CoQ10, magnesium, riboflavin?
Magnesium and riboflavin. So I'll get to that when we get into some of the medications. Those are the two.
Okay.
I mean, I've not really heard of CoQ10 for headaches, but riboflavin and magnesium for sure. Okay, so let's move forward to. Oh, are we done? Or we
Just
have
one
another
more.
question?
Aura with flash of light waking up in the middle of the night without headache. Is that more serious than aura during waking hours?
Can you say that
I don't
again?
know. An aura with flashing light that wakes the
Okay.
patient up in the middle of the night without headache. Is that more serious than having an aura during waking hours? I'm not sure that I've
Yeah.
ever encountered that
Well,
myself.
I would be concerned about it for sure. You know, it's kind of weird. Like, why is an aura waking a patient up? I'm not really sure. Or are they wake? You know, that can just be an acephalgic type migraine. I would inquire if there's a history of migraine. I might be prone to blaming it on that, but I would probably consider that a little bit of a red flag, and I would probably not want to blame a primary headache disorder until I at least looked at that patient's brain. Okay, and maybe
Excellent.
even did a vascular assessment, like looked at their blood vessels, done an MRA on a patient like that. You can get it approved.
Excellent. I think we're all caught up. Terrific.
Okay, great. Okay, so really, really good questions. Okay, another case, 58-year-old male. He's got headaches. The headache began 19 days ago. He knew exactly the day it started. Pain is constant. It involves his right eye, ear, and jaw, and it's very severe. To the point that he sought evaluation in the emergency room. He has no migraine history. He has no migraine family history. He does not have photophobia or sonophobia. The headache is constant, as I said. And he's got no nausea or vomiting. So none of those things that we typically see with migraine. And there's no family history or migraine history. His PCP, so he calls his PCPs like, I'm in agony. I got to do something. And he says, all right, go to the ER and we'll get you worked up. So he goes to the emergency room and they perform an MRI. They perform a vascular MRI of his arteries, and so an MR angiogram. No contrast. He got an ESR and a C-reactive protein. Both were, everything was negative. Everything looked good. He has no pertinent medical history or medications, pretty healthy. So they said, all right, well, next step, go to the dentist and see if there's a dental problem that we can identify. So he goes to the dentist, nothing. So then they said, all right, fine, then go see neuro-ophthalmology. And that's how he wound up in our service. So I walked into the room, and from across the hall, I could see that he had a difference in pupil sizes. And he also had some palpebral aperture asymmetry. So we can see right pupil is a little bit smaller. Can't really tell that it's worse in bright versus dim. I couldn't find a dilation lag, but he did have ptosis in the myotic eye as well. His neuro exam was normal. I won't go into the entire details, but basically motor, sensory, gait, balance, everything was fine. His best corrected acuity was good. So he has a significant history of pain. He's got ptosis, meiosis that lead us to suspect Horner syndrome. And while we didn't find a dilation lag, we always want to look for that when we see Horner's. We didn't feel comfortable with his level of pain. And we felt like, you know, what he's got, that ptosis and meiosis are enough to say he's got Horner syndrome. So what's the most important rule out in a patient who has Horner syndrome accompanied by pain on the same side? And the answer to that question, for the sake of time, is carotid dissection, a tear in the carotid
Mhm.
artery. So, we called the referring doctor and said, hey, listen, I see that they did an MRI and an MR angiogram in his workup. They didn't use contrast. So even though it was normal, they didn't show a narrowing of his lumen. They didn't use contrast. And the doc said, good point. We sent him back to the ER. He got a contrast enhanced MRA of his carotid arteries, and he had enhancement, a ring of enhancement around his carotid artery. So even though we didn't pick up on the narrowing so much compared to the other side, you don't even see the carotid on the other side, actually. He's got this enhancing area that's very compatible with a carotid dissection. So he was having pain from his tear in his carotid artery, which is causing ischemia and thrombosis with secondary ischemia. And after a couple of days of aspirin, he's feeling great. So moral of the story, painful Horners, that's a red flag for that's an ocular feature. That's an optometric red flag. So what are some of these optometric red flags? I mentioned some general red flags, but eye red flags, or is there visual fields, defects associated with their headache? So especially homonymous hemianopsia, bitemporal hemianopsia, but we saw a patient with a central scotoma and an APD, and that's significant. Migraine should not come with any other abnormality. Is there papilledema? Are there pupillary disturbances that suggest that there's some problem, some intracranial process involved? Are there brainstem signs? And by that, I mean, do they have double vision? Do they have evidence of a cranial nerve palsy or internuclear ophthalmoplegia? Is there nystagmus? Because all of those say that there's not just pain all by itself. There is a neurologic deficit. You may have ocular features, but it's a neurologic deficit that really has to be pursued as possibly related to their headache. Okay, so what are some of the examination, the additional testing that we should be doing for our headache patients? Well, we should be doing a very thorough eye examination. And we should make sure we're very, very carefully ruling out anterior, posterior segment diseases, increased intraocular pressure, narrow angles, any ischemic disease. We can have orbital ischemia. I share a case today with orbital ischemia, but any signs of ocular ischemia should be pursued. Accommodative spasm might be related to their headaches. Orbital disease, ask them about pain when chewing, or any hot or cold foods, are they triggering the pain? Any evidence of sinus infection? Sometimes you just listen to the patient talk and you're like, my goodness, you sound like you have a cold. I'm sure this is probably related to your headaches. So all of these things are good. And I always like to document visual fields on my patients with any type of headache disorder, because it's part of our evaluation. It's part of our assessment of their posterior visual pathway. And I tell my students, you start with the front of the eye and you work your way back. Okay, now which patients should have further evaluation? Well, any patient with a history or examination features that are consistent with a secondary headache syndrome. So we talked about all those things. And then any patient exhibiting any of the red flags that we talked about needs further evaluation because they probably have a secondary headache disorder. Okay, so we manage them. Do we refer them? What do we do? So it depends on your clinical findings. If we can find any visual system problems like a refractive error or something, we want to address that. If they have corneal disease, do they have a corneal ulcer? Do they have keratitis? Treat that. They have scleritis or episcleritis. Treat that. That might be why they have headaches. So all of those things have to be addressed. Inflammatory disease, uveitis, all of that should be addressed. But also investigate with any advanced diagnostic testing. If there are red flags that require me to look at their brains, then they get magnetic resonance imaging studies. If you are not comfortable, that's fine. Just you can reach a point where you can tell a patient, look, I'm not finding anything in your exam today that is explaining why you have headaches, so I'm going to let your primary take it from there. Okay, and that's perfectly sound logical management. Okay. Let the physician know that you didn't find anything wrong with their eyes and you're sending them back to them. Okay. And then finally, who's this? If you do have to refer for management of their pain, who do you send them? Do you send them to their primary care? doctor, or do you send them to a pain management specialist? It all depends, because not all primary care docs are comfortable with headache management. Some are very comfortable. And so I talk to the patient, I ask them about how they've gone through things thus far. And if I feel like the patient I saw just last week who I thought had cluster headaches, I'm not sending that one back to their primary physician, because cluster headache is an unusual type of headache. It's not that common. That's best treated by a pain management specialist who's probably seen a lot more of those than the primary care physician. So so think of it in terms of how unusual is this presentation, and then and what's the primary's level of comfort. And it's okay to
And
send them back to the primary, because the primary can then send them to pain management.
And Patty, I think it behooves us, if we're not sure what the level of comfort is to reach out and make a phone call to the primary care physician and ask him or her, what their thoughts are, and share your thoughts. And one thing that I throw out a lot, and I do it on almost all my webinars, I'm going to put it here, is if you ever wondering, should I do something? Should I do something else? Should I do something more? I just tell people, read the chief complaint out loud and see how it sounds, and that will tell you what to do. If you read the chief complaint and it says, a 72-year-old female complains of temporal headache, it tells you got to do something. You've got to be looking at temporal arteritis in a person like that. Now, you might decide that based upon your history, this is really nothing, and you can be wrong, but you don't want to be negligent. So you just read the chief complaint to yourself and see how would that sound if something went wrong and I did nothing.
That's excellent advice that I will now follow, because I don't do that, and I will do it, and will ask my students to do that. So great point there. Okay, so let's see how we do on this polling question. Let's see if everyone is doing visual fields, and it looks like about half of us are doing visual fields. I'm sorry, I'm reading that wrong. So 27% of us are doing it always, for some but not all headache patients, and then we have not usually. So a lot of it depends on what you're thinking is the cause of the headache. And so really we could go a lot of ways on that. And my headache population is biased towards primary and secondary headache disorders. They don't refer me asthenopic headaches, because most people make that diagnosis and they don't need me for that. Okay, let's talk migraine management, and then we'll wrap things up with a couple more cases as long as time permits. So, first thing is, establish a diagnosis. Again, people aren't necessarily asking us to make the diagnosis, but we should at least be able to say, do we feel confident that this is primary versus secondary headache disorders? A lot of patients are frustrated because they say, I had all these tests, but nobody ever told me why. They can't figure out the cause. And I usually tell patients, well, they just don't know the cause, because you have migraines, and migraines don't have a real cause. So you have to just explain that the reason nobody's telling you anything is because they don't know anything, because you have a benign condition that we don't really understand the relationship, but we know you don't have a tumor. And that's usually enough for them to feel a little more comfortable with what's going on. It's very important to have a good doctor-patient relationship, because a lot of times headache management just breaks down if the patient doesn't understand why the doctor's doing something a certain way. They're going to they're just not going to show much confidence in that doctor's ability. Hopefully you have time for some cases where I can highlight that. Finally, just educate the patient about their condition. Let them know, migraine just means they don't have a tumor, but that doesn't mean they don't have pain. And that if they have pain that's unmanageable, then we need to manage it with something. And sometimes people say, well, your MRI is normal. A lot of primaries will do this. Your MRI is normal, so you're good. But no, they have pain still, and that pain needs to be managed. And so I oftentimes will make sure that patient gets referred to someone who's good with pain management. And I like the headache diaries to help identify triggers. So let's start with non-pharmacological management. That is usually identification and avoidance of triggers. Maybe making some lifestyle adjustment, get some regular sleep. Eat regularly. Don't skip meals. That can make you hypoglycemic. Get some exercise regularly. Regular exercise also helps you sleep better. And then if you sleep better, you won't get headaches. Avoid tobacco, caffeine. They can be triggers for migraines. Caffeine late at night will keep you from sleeping and that'll trigger a migraine. Sometimes if patients are just under a lot of stress and that could be triggering different types of headaches, they should sometimes relaxation training or even biofeedback is nice. Do some yoga, lots of things that we can do that can address headache pain or head pain without pills. And a lot of patients don't want pills. Pharmacological management includes either prevention.
Hey, Patti.
Sure. What's up?
As you know, Dr. Shovelin asked a little bit earlier about magnesium and CoQ10, and you've kind of alluded to it. I'm not sure if you're aware. The last about 4 or 5, maybe 6 years now, I've been really kind of, trying to take an allopathic approach, a naturopathic approach, and take an integrative approach. I've been doing a lot of supplements and kind of taking a deep dive as patients are now wanting that type of advice. You've kind of alluded to it, so I just kind of want to say it there, and you kind of said it again, is that kind of the 3 pillars of health, the way I look at it is that there's exercise or the sympathetic system. Then you got the parasympathetic system. You got to stress the body. The body always likes to be yin and yang, omega-3s, omega-6s. One's pro-inflammatory, one's anti-inflammatory. Stress the body, but let it recover. And you talked about sleep, and you talked about yoga and meditation. That's kind of your parasympathetic or relaxed. We talk about exercise, and then we talked about nutrition. And we in an allopathic world like to do things. How about magnesium? How about, CoQ10? And what I found out is kind of that neuron that we just talked about needs, fatty acids. It needs, the B vitamins. It needs blood flow support. That's the polyphenols. Again, the cell membrane integrity, EPA, DHA, that's your omega-3s, your vitamin D, so on and so forth. So what I found is more of a comprehensive approach when it comes to antioxidants. And then that stress, because you talked about it. People were a wreck, right? We don't sleep, we don't eat, we don't do this. No wonder. So I just kind of want to tie that all together as you're kind of hitting these points, but those are the kind of the 3 pillars. So
exactly. And they're pillars that often get ignored by a lot of medical specialists. So it's really important to bring those up. And I've got lots of my friends and neighbors on magnesium and riboflavin. But anyway, so prevention is important. Prevention decreases the frequency of headaches. And then we have acute therapy, and that's to treat the pain when it happens. And oftentimes the approach is a combination of both of these. But let's not forget that combination should also include, just going back to your point, Greg, the lifestyle issues and the homeopathic approaches. So traditional prevention methods, just the triggers, we already mentioned that, but the medications that have been used for prevention are beta blockers. They reduce blood vessel dilation that can often occur during migraines. Antidepressants can target serotonin pathways. I mentioned at the beginning that was a pathway for pain. Anti-seizure medications, or that was involved in the pain pathways as well. Anti-seizure medications, they can block electrical impulses in the nerves. They calm things down. They stop, neuromuscular neurologic transmission, and that's a good thing. It quiets things down. Sedatives do the same thing. They block pain signals. They calm things down, and that makes you less prone to the headaches. Botox, what Botox does is it helps. We didn't understand how it worked at first, but now we know it reduces pain signals that are transmitted from areas like the forehead and the scalp, and that's why that can be useful. Now there's some new.
Patty, can you go back just back by one? Beta blockers. A question came in, and this was actually an off-label pearl from our previous speaker in our last webinar. What about topical 0.5% timolol as a border for migraines? Now, I think it was Chris Putnam at our last webinar talked about a drop in each eye of timolol 0.5%. 15 minutes later, another drop. And so sometimes it can abort, and that was one of the questions that came up. And that person may actually have been on our webinar then. Any thoughts there?
So there are actual publications that support that. I've not had any experience with it. Since they're normally used for prophylaxis or prevention, it shouldn't be helpful for acute therapy of headaches. But I'm aware of, if you Google timolol and migraines, you're going to come up with some papers, but I do not have any experience in that. I'm a little skeptical, but then again, I haven't really read a lot of the articles. There's actually a patient that brought that to my attention. So it's interesting that you bring that up. Some new preventative therapy. There's a class of drug we call GPANTs. How do you know if a drug is a GPANT? Well, it ends in GPANT, so that's how we know. So these are pills, and the two drugs that are used for prophylaxis are Qulipta and Nurtec. You've seen commercials, I'm sure, but these are very, very effective migraine prevention medications. Okay. And what these do is, remember I mentioned CGRP, calcitonin gene-related peptide, as one of the most important neuropeptides that's being released in patients with migraines. So these antagonize CGRP, and they're highly effective migraine preventatives. Now, there's other drugs that target CGRP, and they're CGRP antagonists. There's a group of monoclonal antibodies that are also used for migraine prevention. Most of them are subcutaneous injections. There's 3 drugs here: Emgality, Ajovy, Aimovig. They're all monoclonals that target the CGRP releasing pathways, and they're highly effective at migraine prevention. And when those fail, there's actually an infusion. This is Vyepti. It's an infusion that lasts for 3 months. So you just have to go to an infusion center, get the infusion, and then you're hopefully headache free for a period of time. So these are some newer medications that you may be less familiar with. Now, here's my slide for the homeopathic agents. The 2 big ones are magnesium. Magnesium is associated with serotonin release and regulation of vascular tone. It also has, it's been called the calming, what's the term, electrolyte. It's really good for calming down neurons. You know, I take magnesium every day because it helps me sleep. I sleep better when I take magnesium. So for that very reason, it's just calming. It's calming my brain down, and it helps me sleep. I sleep much better when I take my magnesium. Riboflavin is thought to reduce inflammation and oxidative stress. That goes back to Greg's point on some of the stress we're putting our system under. I am not as familiar with CoQ10. That's not one that's on my list of things I advise patients to take. So I guess I'll do a little bit of homework on that one. Melatonin.
Here's one more comment on that. Is you keep referring to serotonin. We hear about serotonin uptake and so on and so forth. A little bit of a twist for us to think about is 90% of the serotonin is produced in our gut, in our intestinal tract. And we hear all about the leaky gut syndrome and the bacteria and our gut being our second brain. And leaky gut's kind of tied into all these, autoimmune diseases and serotonin and fibromyalgia and headaches and so on and so forth. Wonder if our gut and our diet has anything to do with that too, as we talked about the sleep and the exercise and so on and so forth. Just some food of thought. 90% of the serotonin's in our gut.
And for people that pay attention to a lot of this stuff, I mean, the microbiomes being blamed on a lot of things right now, and just probiotics, prebiotics, anything that raises the diversity of your microbiome is really, really good for this.
I'm going to launch this poll, and you can keep chatting if you want. This seems to be kind of appropriate. How familiar are you with the newer classes of your CGRP inhibitors? Not at all familiar, somewhat familiar, very familiar. Rolling in nicely here. I'll pause it here in a second. Just remember, everyone, this is what makes it synchronous, interactive. And so please try to reply. I think the trend is set here, and here you go.
And great questions.
So good. So I'm glad. Hopefully we're learning a lot from this. And these are very, very new. So it doesn't surprise me that lots of us don't hear about it. A lot of us hear about these things for the first time when we're watching the Hallmark Channel. There's a lot of patients with chronic pain watching the Hallmark Channel, but
Yeah.
they
I have a
target these.
biologic lecture, and I just started introducing those because you did talk about a monoclonal antibody. So that's pretty cool. So
We use monoclonal antibodies for everything now, right?
yeah,
So
how about it?
okay, now here's a really important area where we can come in and help out with our migraine patients, because a lot of the preventative therapy fails. Why does it fail? Well, patients don't realize that they have to give it time. Preventative therapy usually takes a minimum of about a month to kick in, okay? Sometimes even a little longer. So they've got to give it some time. We also have to understand that, if somebody gives you a pill and tells you to take it every day, you're not supposed to take that pill just when you have pain. It's to prevent the headache. So a lot of times they'll say, I took it and it didn't work. And then and you have to ask them, well, how exactly, when did you take it? Did you take it every day? No, I took it every time I had a headache. It never worked. And you have to say, well, you have to remind them, well, that's not the way this medication is supposed to work. You're supposed to take it every day to prevent the headache. Okay, then they have their aha moment and hopefully go back to taking it the right way. The other thing that happens is patients start thinking it was inappropriately prescribed, because if you go back to that list of medications, we had beta blockers, we had antidepressant medications, we had seizure medications, hypnotic medications. So a lot of times everybody Googles their medicine, right? We all do it. We Google everything. They Google it and they say, oh my gosh, he gave me an antidepressant for my migraine headaches. He's not listening to me. I'm not depressed. I have headaches. It's not depression. And so they stop taking it. They get really mad and they think they were mislabeled by their primary doctor, and that's the end of it. So that's one of the problems that can happen. So talk to your patients and find out how they're using their therapy. Now we have acute therapies, and we're probably most familiar with the triptans, okay? They target serotonin receptors, multiple serotonin receptors, specifically the 5-HT1B and 1D receptors. And you don't have to remember that, but I'm going to go back to that in a second. These are found in brain and blood vessels, okay? And so what happens is blood vessel constriction. This has an important contraindication, and that we get some blood vessel constriction from these medications. And because these receptors are found in blood vessels, they can also get blood vessel constriction in their heart. So if they have any history of ischemic heart disease, this can exacerbate it. Or if patients can develop just chest pain from it, in which case we discontinue it. So that's one of the problems that we have with the triptans. They take them when the pain begins. It's also very important for them to take it as soon as the pain starts. Sometimes they feel the headache coming on, but they say, I'll wait till it gets really bad before I take the medicine. It may not work if you wait too long. So it's important to start it right away. Other drugs that are acute therapies, NSAIDs, over-the-counter NSAIDs, are very, very useful in lots of patients with migraines. Opioids, barbiturates, all of these also, they target pain pathways. The latter two, the barbiturates and the opioids, you have to watch those because they are habit forming, and that can limit the usage. Okay, so again, target these two specific receptors. And so any drug that ends in triptan is a triptan drug. So sumatriptan, rizatriptan. There are probably about a half a dozen different triptans on the market, and so they're used quite commonly. They are also available in pill form, quick dissolving pills, injectable forms, nasal sprays, just because sometimes migraine patients are nauseous and they don't want to swallow a pill when they're having a headache. Another very new migraine acute therapy, this is a class of drug called dietans. These also target serotonin receptors, but they target a different one. They target the 5-HT1F receptors, and that's really important because those are found around blood vessels, and I'll get to more on that in a second. But also, their CGRP inhibitors are also are also used as acute migraine therapy as well, not just prevention. So let's take a look. The dietans, the most important dietans, I think it's the only one right now, is Rayval. And again, 5-HT1F. So it's a different receptor than the triptans used. And it prevents release of by affecting these receptors. But muscle around blood vessels doesn't have this receptor, so we don't get the secondary vasoconstriction that we got with the triptan drugs, and that's why it's more effective in patients with a history of heart disease, okay, ischemic heart disease. And then Nurtec and Ubrelvy are two CGRP inhibitors available as pills, and you may remember Nurtec is also used as a preventative therapy, so it's used both ways. Okay, so very, very useful acute migraine therapy. Patients who did not have success with some of the other medications are doing very well with these medications. I just have to move this out of the way. Okay, so there's some updates to some of the triptan, really one of the triptan medications that makes it also more selective for those 1F receptors. Okay, so they've modified sumatriptan. That's one particular triptan drug. And there are 3 formulations where this drug is modified to be more selective for the 1F receptors. And that also can help for patients who have chest pain associated with the regular triptan medications. Makes them a little safer. Okay, finally, one of the things that we can have to deal with is medication overuse headaches. You're going to come across patients with this type of headache. And they just say, look, I have headaches all the time. Every day I have one now. They wax and wane throughout the day, but I'm just never pain-free. So these are patients who probably have what we call medication overuse headaches. We also know them as rebound headaches or withdrawal headaches. And what happens is they just get a gradual increase in their headache frequency. They'll tell you that they started out with headaches maybe once a month and then started getting them more frequently. And they finally reached a point now where they just have them all the time. They basically have a predictable pattern where the headache will occur at a certain point after their last medication dose. So it's like, I know an hour or 2 hours after I take this dose, I know my headache's going to be right back. And to go back to that question about headaches that awaken patients in the middle of the night, sometimes they're medication overuse headaches because they're happening it's the middle of the night when their pain medication is wearing off. So another cause of a headache that awakens a patient. So ask a little bit about when they took how often they're taking medication, how often they're dealing with their headaches, and they may simply have wearing off of their medication due to the patients just they have an irresistible use of medication. They realize my medication's worn off. I know they said to take it every 6 hours, but I have the headache after 4 hours. I don't want to wait another 2 hours to take it, and they just kind of, okay, I'm going to take it 4.5 hours or 5 hours, and they just perpetuate their headache cycle every time that medication wears off. So, or over time, the headaches just fail to respond to that medication. And sometimes just switching the mechanism of the drug will help address this type of headaches. So lots of reasons why this type of problem happens, but it is an issue. It's a common problem in people who have chronic pain and have to use medications on a chronic basis. So how do you treat them? You prevent them. You try to prescribe medications that make the patients less likely to have them. Combination analgesics sometimes are culprits here because they have multiple mechanisms, and you can kind of desensitize your patients to all those different mechanisms. Narcotics and ergotamine, they have shorter half-life, so sometimes that's a problem. It's very important to counsel patients if they're using over-the-counter medications. They tend to use those a little less judiciously because they're over-the-counter, and so they think they're safer. But it really can happen with any medication. So here's a case report. This is a 32-year-old female who has a history of obesity-related pseudotumor cerebri syndrome. She has chronic papilledema. It's been responsive to Diamox, so it's resolved her papilledema, but she does have persistent headaches despite control of her intracranial pressure. So this is a common problem in patients with pseudotumor cerebri. A lot of them have an underlying, if they have the migraine gene and they get chronic intracranial pressure increases, that sometimes will trigger almost like a chronic headache pattern. So even though we lower their intracranial pressure, they get persistent headaches because their migraines are just kicking in. So we use Topamax in her case because Topamax will address both the headaches and her intracranial pressure. It's an anticonvulsant, but it does have some ability to inhibit carbonic anhydrase, so it can lower intracranial pressure. It was poorly tolerated. We also tried a tricyclic antidepressant on her. That was also not effective. Here is her OCT. So the first concern is, does she have an increase in her intracranial pressure and thereby evidence of papilledema? And she doesn't. She looks pretty good. She's falling well within our average T-SNP curve. She has a little bit of compromise to her ganglion cell layer, so that may be due to some mild compromise to her RNFL. May or may not be related to her history of pseudotumor. But also, if you notice here, she has really tiny optic nerves, so she may just have anomalous optic nerves that are giving her some anomalous results here. Anyway, is there a better way to address her presentation? So she's failed a number of therapies. Nothing's really working. So what we did in her case, and I want to, just for the sake of time, we'll just jump right in. I'll tell you, we added Nurtec, so CGRP inhibitor, oral medication, and that was really helpful in addressing her pain via a different pathway. And she did really well with that. In fact, I just saw her last week. She's doing great on regular use of Nurtec. Another case, and we'll just wrap up with just a couple of more cases, and then I'll turn it back over to Greg. So 21-year-old female complains of headaches. She's got a throbbing pain in the back of her head. She was seen in the ER 2 to 3 months earlier, diagnosed with migraines, and since then, the headaches have been increasing in severity. They're nearly constant. She's using over-the-counter Tylenol and Excedrin with minimal effect. She reports that the headaches are accompanied by photophobia, but no sonophobia. She also has eye pain. It worsens with eye movements. She's got this history of binocular instability. 2 years ago, she was treated with a course of vision therapy. She had an episode of gaze-evoked visual blur during her vision training treatment period. Never really found out what that was all about, but she was concerned about it. She consulted with a neurologist who prescribed naproxen, also prescribed anti-anxiety medication and some ibuprofen. She did not comply because she had gastric discomfort, probably would too if I had 2 NSAIDs going at one time. Patient also admits that she's got horrible anxiety. It keeps her awake at night, so she's not sleeping. She doesn't want to go back to the neurologist because she felt that the neurologist made her anxiety worse. Quite frankly, when you see, this use of medications, I kind of feel like, she might need a different type of intervention as well. So what do we think of the treatment option? I already mentioned she's using 2 different NSAIDs, and there are other ways to treat headaches. They sound migrainous because she's got the photophobia. She has a strong migraine history, but she does have a possible asthenopic component that we might want to address. So she is a college student having a lot of difficulty concentrating. She's under stress because of her course load. She does use marijuana from time to time. That might help her, I'm sure, given that marijuana is good for a lot of pain problems. She's agitated during the course of the examination. So bad is her agitation that she frequently breaks down in tears. And so they sent her to me to kind of sort it all out and figure out what to do with her. 2020, she got good pupillary findings. Motility is fine, but she is, reporting pain on eye movements. And then finally, her ocular health, it shows that she's good. She has no real problems. Her neurologic examination is fine. She does have some abnormality to her visual field, but it's not really pointing to a clear posterior visual pathway problem. She does have a lot of fixational errors, so it's probably not at all, you know, not all that reliable. We didn't feel that they followed any type of pattern that was relevant to her headache history. She probably just didn't do well because she was in pain. We repeated it. We got a totally different looking visual field. So, you know, it's not, they're not real field defects. So what type of headaches does she have? I mentioned there may be an asthenopic component. She does have this history of primary. Does she have red flags? You know, don't really see any clear ones that we can identify. So our rationale for asthenopia is her history of binocular instability and the eye movement discomfort during her examination. Rationale for a primary headache disorder is her history of migraines, and she does have some associated features that are typical of migraines. We didn't necessarily identify triggers, but she's got anxiety, so that's probably a trigger itself. She's not sleeping well, so that's probably a trigger. Stress is probably a trigger here. We really didn't, as I said, identify any clear red flags. So how do we want to manage this one? We need to take a really broad approach here. Okay, we really need to unpack a lot of things. So what we did was we did refer her to a pain management specialist because we need to break her pain cycle. It's really bad. And she was given butalbital, which is a combination drug that really just knocks out the pain from different areas. And we also felt she needed to address her anxiety or she was going to get herself back into the same problem. So we got social work involved and got her to someone who could address her anxiety more appropriately. And then she was prescribed by that professional. She was prescribed an SNRA, venlafaxine, an antidepressant medication, which also has good use for not only anxiety, but also anytime you interfere with serotonin pathways, you can also address it can also help with migraine prevention. She was also given some, because we knocked her pain back, decreased the frequency, she then was able to start using sumatriptan for some episodic pain. So she was a hot mess when she came in, but we got her into good treatment options that worked really, really well for her. And so it was the optometrist, not the neurologist, who got the ball rolling to a better treatment option. I'm going to do one more because I need to wrap up in about 5 minutes, right, Greg? So 45-year-old female,
Yep.
Headaches for 15 years. They're unilateral, moderate in nature, anywhere from about 6 out of on a scale of 1 to 10. She has photophobia, frequently associated with the headaches, and a recent increase in the frequency. She now gets them daily with no relief from any of her medications. Her physician is giving her acetaminophen and hydrocodone in combination, and she's using that several times a week without relief. And so I said, how are you getting that refilled? And she said, I just get refills. Okay. Sometimes she uses the medication just to prevent the headache. She knows she has a big day. Maybe she has to deliver a webinar. I don't know. She's like, I'm just going to get up and I'm going to take that medication because I don't want to get a headache that day. She has no identifiable triggers. Her best corrected acuity is 20/20 in both eyes. All components of her exam are normal. So what kind of headache do we think she has? And are there any red flags? So I'll cut to the chase on this one and say she is using an acute medication, an abortive medication, several times a week. And anytime you're using a medication for abortive, the abortive headache approach or acute headache alleviation, if you're using it more than 3 times a week, you can put yourself into a daily headache pattern. And that's exactly what was going on here. So we know she's got longstanding headaches, which makes us migraine seem like a really good diagnosis here. She does have a change in pattern. That's a red flag. But if you look at what she's doing with her headaches, it kind of makes sense that she has a change in her headache pattern because she's taking too much pain medication. Okay. So always ask about that headache frequency. Don't just ask them, oh, this isn't working. Ask them how often they're taking it because she needs to be on something different. So what did we do with her? similar to the other patient, we were very concerned about the habit-forming nature of her medication, so we needed to get her off of that. So what we did was we sent her to a pain management specialist. 6 months later, she came back. Her doctor initiated medication called Migraine, which just knocked it out for her, and now she's just on episodic pain medication. She doesn't need any prophylaxis. She's just getting headaches when she gets her menstrual period, and so she's doing really, really well. So what is Migraine? It's a combination acetaminophen, okay? So that's a nice pain medication. It also has dichlorphenazone, which is a sedative. That's a nice, calms down the central nervous system, also disrupts central pain pathways. And then they gave her some isometheptane, causing some narrowing of the blood vessels. That also helps break that cycle of neuropeptide release. So it did the job for her. So this is where pain management specialists can do really, really well by your patients, because they know how to deal with the patient that's coming in with these types of migraine variants, the rebound headaches, all of the different types. They sometimes need intervention to kind of clean up the mess that happened after medication overuse or just inappropriate treatment. So in summary, when you're seeing these patients, ask yourself, are they related to any abnormality in the visual system? Is there asthenopia? Does it sound like a primary headache disorder? Are there red flags that suggest a secondary disorder? And then do they have medication? How are they using their medications? Okay. So we have one more polling question to end things.
Yep. So if there's any final comments on your summary slide, I figured I'd run that polling question. And then there is a question that came in that says, do you find that Excedrin is helpful for migraine headaches?
Okay, so if you're referring to, there's Excedrin migraine, which has a little bit of caffeine in it, and that's why it makes it really, really effective. And I have loads of patients who have episodic headaches that don't occur that frequently, and Excedrin migraine is wonderful for them because they get the acetaminophen, then they get the caffeine. Caffeine, by the way, is a nice abortive medication for migraines. When I used to get migraine with aura, first thing I do is grab some caffeine and take that, and then take some either Motrin or Tylenol, and that usually does the trick of staving off that headache, or at least diminishing its onset. And I have loads of patients who do love Excedrin.
And I think you got a result here from first question. I think you got a shift.
Yeah, I don't remember exactly what the first one was, but I'm glad to see that there's some people who have moved into that very comfortable range. It takes a little time. I used to hate managing headaches because I was uncomfortable with it. I've reached a point where I actually enjoy seeing patients with headaches because I've seen it enough, and it's kind of like the same things are going wrong on a lot of the patients, and it's fun to kind of make some sense out of it. So I really thank everybody for their time. Thank you for just your attention. Thank you for some really, really great questions. And thanks to Joe and Greg for their input. It just made it that much more fun to have some really good discussion going on with all of these cases. So I hope to see you guys again sometime.
Oh yeah, we really thank you for doing this. That was a very high level, tremendous presentation that covered a lot of material. I think people feel a lot better about this. In fact, you moved anybody who said not at all comfortable out of that category. So I think that's tremendous. Thank you so much.
Okay, have a great night, everyone.
Thanks, Patty. I'm just going to share this slide right here, Pat, if you want to see it. Whenever I talk about, the cell membrane, this could be an axon that's in the ganglion cell. This one's here talking about brain health. We're talking about homocysteine. You can see all the supplements here are all the nutrients that are needed. Energy metabolism, neurotransmitters, neurogrowth, impulses, membrane stability, and blood growth. Remember, we need a lot of things in there. So here we talked about the CoQ10, we talked about riboflavin. It's just a lot is involved. So
yeah, I think a good sequel to this talk would really be, maybe the homeopathic and lifestyle approach to migraines.
I think maybe me and you should do that.
Okay.
All right,
Get
perfect.
it together.
We'll do that.
Care.
Patty, again, Joe has echoed. I'm just going to echo what Joe hit the nail on the head. Thank you very much. All the questions have been answered. This was Optometric Role in Diagnosis and Management of Headaches, a synchronous virtual course. Patty, you hit a home run. Looking forward to seeing you in Pittsburgh in a few weeks.
Great. Looking forward to it as well.